Uh, Thank you all for joining us this morning. We're going to talk today about the golden thread and ensuring documentation that enhances person-centered care. We'll preface this with documentation trainings tend to not be super lively, so we're going to try to make it as entertaining as possible. And please jump in. I think a lot of this is probably things you're already doing. One of the things about documentation, particularly for Medicaid documentation, is really how you write it and what the narrative is. So that's really what we're talking a lot about today. But I have no doubt that you all are already doing a lot of this. And so it's really just like, how are we framing things? So if we want to go to the next slide, we'll do introductions. So if you want to drop in the chat your name, pronouns, title, organization, and then a food that you love that a lot of other people might find odd. And Teresa, I should have started this. I don't know if I have my food. So I can get started. I'm Jordan Gully. Some of you probably already know me. I'm a senior consultant with TAC, and we are a consulting firm based out of Boston that works with human services and housing agencies to really just support with policy and practice, so individuals can live in the communities in which they choose. So I don't know what my odd food is. Teresa, do you have one?
I don't know how odd it is, but people feel really strongly either one way or another about mine. So I'm Teresa, Senior Associate at TAC. Um, and I would say, like, I'm a really big fan of oysters, and people either love them or they hate them and are so grossed out by them. So probably like 50% of the world thinks that that's disgusting, but I love them.
Interesting. I guess I can this you sparked as the ones are starting to come in and it's like these might be things that we'll try later, like chocolate chip chip and Cheez-Its dipped in sour cream. I think mine was like a pregnancy craving. I would often roll cheese in pickles and just eat cheese pickles, which still seems weird, but is still appealing to me. So I think it's a carryover. Um, but
Oh,
I see a
someone
lot.
said milk and Pepsi. I've never heard of that before. Interesting.
Chicken salad sandwich with peanut butter. Man, you guys are not disappointing with this. This is great.
Oh.
All food is
Wow.
good to me. I hear that. Awesome. Well,
Wow,
keep
these are
these
interesting.
coming. I'm loving these. I think we're also, looking to get inspiration for our meals. Cheeseburger with peanut butter and jelly. You guys are great at this. I was not good at this one.
I've heard of that before, though. That's called like the Elvis or something. Like, I don't know, something like that. Interesting. Very interesting.
Well, keep them coming. We're gonna collect them, but we always just like to get people talking in the beginning. So feel free. It's a small group. We're gonna try to make this as interactive as possible. Again, documentation is not always super thrilling, but we definitely want to make this as interactive as possible. So next slide, we'll talk a little bit about kind of what our objectives are today. So we're gonna spend a little bit of time just talking about medical necessity. This is really for informational purposes and understanding. EOE, OE is the one that is continually assessing for this. So this is where conflict-free case management comes in. But in doing documentation for Medicaid services, it's really important to know kind of medical necessity. So we'll spend a little bit of time on that. We'll identify necessary components for documentation related to service and really the essential elements for effective service plans, intervention, and service notes. And we'll talk about gain an understanding of the golden thread for documentation and how individuals' connection to services are really guided by that golden thread. And we'll utilize tangible techniques to talk about effective documentation, as well as talking about some common pitfalls that people might encounter in documentation. So we'll have a couple opportunities to really talk about assessment, planning, intervention. So really want you all's input. I know you're doing this regularly in your work. So if we go to the next slide, we're going to just give you a high level overview of what the agenda is. So first, we'll start with medical necessity and overview on establishing the service need. Then we'll spend some time defining what we mean when we say golden thread. And we'll spend a majority of the time really talking about your assessments, your housing search, and your support plans, and how do you frame those in a way that are really supporting the need for the service, as well as talking about the service encounter notes or engagement notes, what should be in those different formats you can use. Everybody tends to have a preference of the format they like to use, so we'll talk about that. And then we'll spend a little bit of time just talking about an example on how you might walk through that golden thread, and we'll leave some time for questions and answers as well. So if you want to go to the next slide, we'll jump on in. So we want to start with what is medical necessity. And since it's a smaller group, if anybody wants to be brave and come off mute, does anybody know what medical necessity is?
I'm just guessing because I don't know for sure, but that it
Sure.
means something that a doctor has determined is medically necessary, and you have some kind of proof, documentation, something, a signed note that says what it is.
Yeah, I think that's a great guess. So yeah, this is a concept that we're going to talk about just to level set for Medicaid services, and so if we go to the next slide, we'll really dig in. But Ramsey, that's pretty spot on for what medical necessity is. So. In defining it, medical necessity is kind of a broad category that refers to services that are appropriate in terms of type, frequency, intensity, duration, and considered effective for a person's need. In this particular instance, we're talking about
Jordan had shared that her internet was a little unstable earlier this morning, so I will just jump in here and try to cover her content until she's back with us because she is frozen. Not a terrible frozen screen picture though, which is nice because sometimes they're just really they're awful. Um, so as Jordan was saying, I think, oh, you're back. Okay, I was just jumping into your content, so you go, you go. Oh no, now she's gone. Sorry, everyone, for the technical difficulties. So I will continue with her content. And so I think one thing that it's important to know, it's like, right, it's not a doctor, but it's anyone who is kind of in charge of determining whether the service is appropriate. And medical necessity is really important to really kind of back up that you are providing an appropriate service to respond to that person's needs. And so that can be a health condition, that can be a behavioral health condition. And the idea is that the intervention that you're providing um, reduces either their symptoms or impairments or challenges that they're facing. And a lot of what this work that you all will be doing is related to like those social determinants of health. But also you'll be, linking folks to get their other needs met as well. And so it really is just a standard to determine whether or not the service should be covered for the member, right? And that is kind of on us to prove, right? It's like, so we're saying through multiple different things. So, well, all of our different documentation, right? And so in this situation, OEO does do the determination, but it's on the rest of the folks to assess and document and do service notes, all that kind of tie back in to medical necessity to just show that the service is needed in an ongoing way with the frequency that you're providing with it, with the length of time that you're spending with that person. Any questions there before I move on? And I see that Jordan is back.
Sorry. We had a
And
feeling it was going to happen today. My internet is struggling, so we will make it work. So if we want to go to the next slide, as Teresa necessity.
Jordan. Oh,
Am I-
Jordan, you're cutting it in and out a lot.
I'll let you take it then.
Okay, yeah. Um, okay. So this is just kind of a table of what the criteria for medical necessity for this project, as defined by OEO, is. So you have your health needs criteria, and you probably are all familiar with this, and your risk-based criteria. So health needs criteria can be a behavioral health condition where folks, there's a need for improvement in functioning or stabilization of symptoms, or maybe they're in a period of life where their behavioral health condition has deteriorated somewhat, and so we're working with them to um, improve their functioning, basically. And the other health needs criteria is the ASAM, so talking about substance use, um, and where they need to at least meet the criteria for outpatient level of care. Um, Looking at how people are functioning in terms of their activities of daily living. Um, so that could be impairment related to a behavioral health condition. It could also be related to a brain injury. So are people able to cook, clean, take care of their hygiene, things like that? And for this project, there needs to be an impairment in functioning for at least two ADLs. And then also looking at complex physical health needs. So an example might be unmanaged diabetes, right? Where there's a need for improvement, or their health condition is impairing their ability to function. Or like kidney disease might be another good example. I don't know if this sounds familiar to all of you, but we had a lot of folks when I was working in shelters that needed support in following through with dialysis. And of course, if they were not following through with dialysis, that would inevitably end up in kind of like a health crisis. And so helping people manage that and maintain their care. And then lastly, anyone that has measurable delays in their cognitive abilities, in that impairs their functioning to a degree where services would be necessary. And so, second to the health-based criteria, there's the risk-based criteria. So there's at risk of homelessness as defined by HUD, history of homelessness, um, or history of long stays in institutions or residential levels of care, history of frequent ED visits or hospitalization, involvement with criminal justice, um, history of like housing instability, so lots of moves, losing their housing repeatedly because of their behavioral health condition or because of their substance use or because of their inability to um, take care of their unit, and then being at risk of institutionalization and feeling like if they had the appropriate support in the community, that that risk would be reduced.
And I'll try to stay off camera for this, but Molly put in the chat that this is specific for PSHA services.
Yes.
And yeah, so we're framing of like medical necessity is defined by the conflict-free case manager for PSHA services, and we'll talk about how you maintain billable services throughout in the rest of this conversation. So.
Yes, thank you for saying that. Sorry, when I was saying this program, that's what I meant. But if that was not clear, then I apologize. All right, I will go to the next slide. Unless, Jordan, is there anything else that you wanted to add for this slide?
No, I think this is just so when they're looking at if you're eligible for services, this is what they're looking at, and this is what we talk about when we're talking about medical necessity that would be reimbursable by insurance.
Thank you. Okay. All right. And we've kind of touched on this. Oops. A little bit, but why is medical necessity important? So one, it ensures that you're going to get reimbursed for your service. So that's one reason, but that's only one reason. Um, but it's an important reason. All of our bottom lines are razor thin, right? It helps justify the service. I think this is the more important reason from my perspective is we want to practice ethically. We want to be providing a service that the person really needs and that is appropriate to the challenges that they're facing and will ideally support them in moving forward from that, right? It also provides a clear framework for deciding what to do with services, right? So it provides a clear framework for whether or not it's time to terminate services, whether or not we should increase in frequency of services. So all of those things are kind of guided by medical necessity. And then it makes sure that it's clinically indicated, which I did already touch on in some of the slides before, but we just want to make sure that we're matching the person to the appropriate service that will actually be supportive and helpful for them. And I see that Marissa linked the provider manual so that you can get even more in-depth information about the medical necessity criteria for PSHA. Thank you, Marissa. And I think just to touch on a few kind of overarching points about medical necessity, in this service, the criteria is pretty clearly defined. So there's not one specific way though that you're going to document meeting that criteria necessarily, but that flexibility can be a good thing.
Whatever. Perfect. Like, did she say June 19th? 18th. Remember to mute yourself, folks. Thanks.
Thank you for saying that. And so again, requirements for matching the service, we want it to be a service that can relieve a person's symptom distress and impairment. Um, it must be indicated, treatment must be responsive to the specific diagnosis. So that's a little kind of beyond the scope of this service, but generally when we're talking about medical necessity, you would be trying to identify interventions that match the person's diagnosis. We all know there's best practices for a variety of different conditions. We want to make sure that the service is appropriate and that it's not just the intervention you're delivering, but where are you delivering it, in what setting, and how frequently are you delivering it so that it meets the person's needs. And it, again, efficacious must be likely to be effective based on what we know of the evidence.
And I'll just add that for this, so when you're talking about medical necessity, it's often framed in a clinical framework, but this is part of why there's health-based and risk-based, that it is health risk. So treatment is indicated, the specific diagnosis might be housing instability. And so then the intervention for treatment is housing services. And so again, Molly just put this in the chat, but this is related to the conflict-free case management piece and determining medical necessity. The reason we are spending time on this is that it's important for all of the services. So understanding medical necessity and how services are deemed eligible is important because in your documentation, you're still providing services under that medical necessity. So there's a housing need, that is what's deemed this person eligible for the services. So all those services should be meeting those goals that are defined in that original plan. And we'll talk about this as we move on, but wanted to just spend a little bit of time doing a little bit of orientation into medical necessity, because even though you're not holding it, we feel like it's important to have kind of that context and understanding of what goes into Medicaid services and billing for Medicaid services.
Yeah, and I think it's also important to remember, like, no, you're not the one for this program that's making that final determination, but all of your documentation should back up the idea that the service that you're providing is a match for the person that you're serving and for their specific needs. Okay, so we will move on to person-centered documentation. And this may seem like a silly question, but why is it important to document? You can put it in the chat. You can come off mute. From your perspective, why is it important to document? See something in the chat. Proof of services provided, right? So there's that saying that we all know if we didn't document it, it didn't happen. Not Medicaid billing, yes, and a really important one, continuity. Staff changes, or if there's multiple people serving one member. So continuity within the agency, or if there is that staff turnover, which we know is a real challenge right now with the workforce shortage in behavioral health services.
Yeah, it
Really
can
helps.
also
Yep, go ahead.
help demonstrate like chronicity if there's any, need to prove that, then it's good to have records.
Yeah, absolutely. And then I think, Molly, you're saying creating an arc of interventions in response and helps kind of like process what you're doing with the person. Um, Absolutely. And also, I think kind of it gives us a nice picture of like how people have progressed over time and can give us some insight into whether um, are our interventions effective? Do we need to pivot because we're seeing progress here in this goal, but we're not seeing progress here in this goal. And so what is that about? Maybe I need to change my approach. So I think it can be good for us individually, but it also can be good for like a team approach to make sure that we are ensuring continuity care. And then there's the QI piece too, right? So if you're a supervisor, you're looking at someone's notes, you want to make sure that services are being delivered in the way that aligns with the mission and vision and values of your organization. In one way, you can kind of get a peek at that, and also, in adherence to the regs, but um, more importantly, I think mission aligned, and you can get a good sense of that through documentation. So thank you for all of those answers. And so I think when we're talking about quality documentation, you've touched on a number of these, right? So we ensure that services are person-centered, and that informed decision making about the approaches that we take. It makes sure that we're capturing. So when we're like doing quality documentation, I think um, one piece of that quality is really capturing the voice of the person that you're working with. Like that is a part of quality documentation. And so if we're starting there, then we're making sure that we're tying everything else back to that member's voice and choice. So we are ensuring that services are person-centered. We're informing our interventions based on what we're capturing of what their needs, wants, and desires are. Um, and it just makes sure that people are getting the services that are necessary and appropriate. So you can kind of take a look at the documentation. You should be able to see that this person's services match their need, which I know I keep repeating, but like that's really what we're showing. Um, and so other reasons are to strengthen claims, build and reduce improper payments or kickbacks. Um, and then someone already mentioned this, but that transition between either staff or maybe to a new service, there's some continuity there if you're documenting well. So I think before we go through all of these, what to you all, what does the golden thread mean?
And also, is it a term you've ever heard?
Oh, I see people shaking their head. Okay, well, you know what they say about assumptions. I was assuming this was a term folks may have heard. Okay. Um, is
It's
there
a
anyone
term.
that has heard it that wants to share what they think that means?
The reason I asked is it's a term that's often associated with like medical and Medicaid billing, so that's why I wasn't sure if people had heard of it.
Yeah.
And I think this gets back to probably what you're doing, but the name for it, right? So it's really talking about like the consistent presence of relevant information, starting from assessment through planning through notes and ensuring that there's a consistent thread that threads through every piece of your documentation. Essentially that somebody could pick up that chart and read it like a book and know exactly what you did, exactly what was going on, what did that person need, what did they say they need, what did you try, how did you pivot. It's kind of, that's literally the Jordanism of what golden thread is.
And if you think about it, like I'm a visual person, so when I think about a thread. It's like you're making a stitch, right? So you're kind of starting with the assessment, and you should kind of see how the assessment informs the plan, how the plan informs the goals, how the goals inform the intervention. Like you're closing the loop, right? You're making that stitch, um, all the way through the service notes. So we should just see kind of like a common thread, not to be repetitive through all of these. So, excuse me, I have a little cold today too. So we're batting 1,000 for this training. Um, so like Jordan already mentioned, it's the consistent presence of relevant information throughout all of the documentation that really ties it together and helps us understand from the assessment to the service notes, why are we doing what we're doing? We identified the need, what we provide should meet the need, and it should all flow through that. And our interventions and what we do when we're with the person providing services should be reflective of that. So for this service, it begins at conflict-free case management, where they're going to define the problem and some goals. And then it moves to the housing search and support plans to get kind of a clearer sense and be more specific and define interventions to move those goals forwards. And again, it's just a logical process, and it helps us understand the flow of services and the rationale for why we're doing what we're doing with the person served. And again, so this is just a little bit of kind of like a visual overview of the process for this service. So conflict-free case management is establishing medical necessity in a high-level plan. The provider housing assessment completes a more detailed plan of care. And the housing search and support and crisis plan utilize the assessment that you do to complete the interventions, the goals you're defining with the member, and also like how are we supporting them in a crisis. And um, after you're completing these pieces, you're just regularly documenting your services. You'll reassess when you need to. I think we talked about this in one of our collaboratives, kind of that need to have ongoing assessment, pivoting your approach and reflecting that in your documentation. And then lastly, documentation in the golden thread should kind of lead us to when someone is discharged, why was that decision made? Why was it an appropriate decision? Um, and what was the need behind the transition? So to ensure that we're doing this, we want to focus on three things. So one, we want to make sure that we're assessing the needs as the person defines them. We're assessing strengths, and we're assessing the impact of what their needs are. From that, that's going to drive. So number one is going to drive number two. From that assessed need and strengths, we're going to identify how those will translate into goals and objectives that are obviously justified. And then we're going to define interventions. And when we're doing our service notes, we're documenting the provision of those interventions. And you can kind of see the different pieces of documentation for this service that would support that. So there's a standardized housing assessment, it supports number one, housing search and support plans supports number two, and then all engagement, so how you're documenting your sessions, supports number three. Okay. And so now we're going to pivot a little bit to talk about the assessment process. And I know that we did have a little bit of a focus on this in one of our learning collaboratives, but I think it can't be overstated how important our approach to assessment is. So I think first and foremost, the thing that we want to focus on is capturing the member's story and their needs and preferences. Also establishing kind of a baseline understanding of what their strengths are, what their skill set is, but also what their challenges and barriers are. Some behavior they might want to address that kind of contribute to some of the challenges that they're experiencing. And then lastly, like, what do they need? And I think, it's really important to start from a place of asking the person in front of you that and not trying to determine it for them, which I don't think I need to tell this group. This group is really strong in that regard. Um, but it's really, I think, a long time ago, at least when I was in social work school, we had a whole class on like diagnosis and how important that was. And I feel like we've moved away from that. And I would encourage you all to just think of a person holistically, um, and focuses on multiple dimensions, rather than just kind of like how are they functioning related to their behavioral health, right? There's so many other things around that, including the social determinants that the service really focuses on, and how are we assessing in each area and not just kind of getting kind of stuck on one specific thing, which again, I think this group, from what I've heard from you all, is pretty strong there. But you do see services sometimes where people are like, oh, they're hearing voices. We have to focus on med management. Well, why? Did the person tell you that? Or is that something you're kind of projecting onto the process because of what you think you know about them? And I think it's also really important to remember that things change over time, but not just that, like in this relationship, people are not always going to give you all the information up front, and nor should we expect them to. I don't think. I don't think that's a very trauma-informed approach, as we talked about in our last training. Um, so we're always going to be getting more information. One, because change is part of this process, but two, because we're just going to learn more information over time, and it's going to kind of narrow our focus in, and it's going to help us make better informed decisions. But it's always going to be kind of an ongoing process. And at any point in time, we might use our assessment skills to pivot our approach and to look at things differently with the person. I think we all can relate to the fact that you learn new information, you might view a situation differently. Um, and that will certainly happen in the provision of these services.
And Teresa, I'll just add that I think part of what we framed up with the medical necessity is really the need is there's a housing need. And I think one of the things that you all are really great at doing is looking at so many different things impact housing. There's social determinants of health. There's, physical health that can impact housing stability. There's all these different factors, financial, that can impact housing stability. And so because, the task order is supporting with housing as well as, this health related need, there's a lot of opportunity to assess in basically the 8 domains of wellness. So looking at financial, looking at employment, so all of that impacts housing. And so part of the assessment piece is always looking back at, okay, where are their strengths and where are their challenges of functioning, and how does that tie back to housing? How does that tie back to the housing stability, and how might it impact their ability to maintain in housing, and how can we support them with ensuring housing stability? And so that's kind of the theme that we'll hear throughout, is through the assessment, through the planning, through all of that, is it's tying back to that health need and then the risk need.
Yeah, absolutely. And that was a great segue to this slide, which talks about kind of like what a housing-based assessment is meant to accomplish. Um, so the buckets you can see on the right-hand side of the screen. So I think first and foremost, what does the person know about housing resources and how to navigate those? I think that process is complicated for anyone, and certainly someone um, who you all might be working with who has been focusing on their survival needs for a long time might not have a ton of housing, or they might because they've been navigating the system for so long. But I think it's really important to get a sense of that. Like, have they done applications in the past? Is this their first time pursuing housing? Um, or have they gone through this process many times? And so that will shift your approach. Um, what are the skills and resources they need to obtain and maintain housing? So I guess kind of assessing what have they already accomplished, like what have they identified that they can, and again, we're not making this assumption for them, what they have they identified that they can do on their own, and what have they identified that they might need some support with. So for example, no problem filling out housing applications, but following up is a big challenge because it's hard to keep a cell phone and it's hard to keep my documents. And so they have a big skill set because those applications are actually like difficult. I remember doing them with people early on in my career and being like, oh my gosh, like what is this? Um, and also, but also identifying some gaps, right? And that might not be something about the person, but it might be about their circumstances. And so where can you assess like what will their role be and where will I support them? And then tenant selection barriers in like the landlord screening process. So being really familiar with that criteria and getting a sense of what a person, what barriers a person might have to obtaining housing. So is it Corey? Um, is it they need something that's accessible? They need some support in their apartment so that they can even enjoy living in the apartment and accessing the apartment. And then similarly, what are retention barriers? So kind of learning about their housing history and talk about um, maybe what were some challenges in the past or what are some challenges we can anticipate. And so let's already start thinking about a plan to address those so they don't become something that puts you at risk of losing housing again. And so I think one of the ones we hear all the time is I don't know, boundaries with guests, right? So maybe someone, a lot of folks I think shifting into housing sometimes feel guilt that they still have folks that they really care about that are still out there. And um, certainly is something that could be a lease violation in many situations. And so how do we navigate that? And that's just one example. There are so many, but that is one. And then personal preference. I think this is one that's really important that we don't spend enough time on sometimes, um, because we so badly want people to be in housing and in a safer situation that certainly I've seen over time, and I don't know if this resonates with other folks, that we want them to take the first thing that's available, but if the first thing that's available doesn't meet their needs, then we might be unknowingly creating, with good intentions, I will say that first, with good intentions, we might be creating a situation that's a little bit untenable, right? So if um, I was talking to a team for a different project, and one thing that they identified for someone they were working with is like they just because of how easily overstimulated they get, they identified really wanting only to be in like a multifamily and not like a big apartment complex because the number of neighbors and the amount of neighbors was really triggering for them. And so knowing that helps set them up for better success. Whereas had we put them in a situation where they were having to manage all of those relationships, we could have created some challenges. And so some categories you might consider is like who do you want to live near or not? What kind of housing do you want to be in? So that multifamily with maybe two neighbors or one neighbor versus like 20 neighbors, that's a big difference. And then what are the resources in the areas or the activities you're connected to in the community? Because we also know that building that meaningful life outside of just being housed is really critical to sustaining housing. So are they connected to faith-based or cultural activities in a certain area and they really find that important connection supportive, so want to stay near that? Do they need to be walking distance from a supermarket or do they need to be really close to a bus stop? Certainly, like if you're taking public transportation, getting groceries is a whole different challenge than it would have been if you're someone that drives. And so taking all of that into account and really focusing on the preferences that will make someone want to stay and do the work to be in this housing. And lastly, making sure that we're promoting choice whenever possible. Um, so really laying out all the options, letting people decide, and talking through all the different options. And again, not nudging them in one direction, even though it can really be tempting to do that when you want someone to get from the street to housing where you would think they'd be more safe, but slowing down, I think, and making sure we're being intentional about how we go about it. Any questions before I move to the next slide or thoughts, comments?
Teresa, I just want to ask a question to everyone because I know
Yeah.
you're all doing this assessment, you're engaging, and I think the personal preference and opportunities to promote choice is one of the hardest things. Like we obviously assess for it, and then the reality is resources are hard. And so during this assessment, how are you kind of balancing those with we need to assess and ensure there's member choice, and also the reality is that sometimes we work in remote areas where maybe choice, and so how are you kind of both assessing for and engaging in reality-based conversations with them? And is this a challenge? Maybe it's not. Maybe,
I think it's a challenge. I think people are so focused on, I think like what you just talked about, a lot of people don't think about their own what's best for them, where's the best place, because there's so little housing that they want to take whatever opportunity is there. And then some, it's the opposite. They are really fixated on being in a certain spot, and it might not be the best place, but that they're really fixated on that. And so trying to help them see it in a different way is really challenging, I think.
Yeah, I'll echo all of that. And I think for providers, obviously, it's so hard because that's like as you said, the end goal, and it can be hard to pivot from that. I think one potential way to talk about it is, we want to meet all of your wants. And the folks we're serving know that it is a really, really, really hard market out there. So, it's easy to connect on that level, but I do think there can be a reminder of you can have a couple non-negotiables. We're not going to get everything you want, likely, but if there's a couple non-negotiables that really connect to your health and well-being, let's not forget what those are. Thought.
Yeah, absolutely. I really like that way of framing it because I think you're right. We don't want to get stuck in a situation with limited housing stock where we're rejecting everything because it doesn't meet kind of like the pie in the sky picture. But there may be some things that are non-starters or that really would set people up for success or challenges. And so knowing what those are, identifying during the assessment process can be really helpful. And I'm just seeing in the chat, talking about timelines are important. Yes, I definitely think, establishing kind of like some expectations around how long this might take is really critical. I mean, one, for maintaining people's hopefulness, right? Because if they have a realistic expectation, it can kind of combat those feelings of hopelessness when things get a little tricky or they get held up. And also love the idea, Marissa, of thinking about, okay, so maybe this is not your perfect apartment right now. And so this doesn't have to be the end of our work together. Like we can either pursue things that make the space that you do find more ideal, or we can look at this as kind of like a temporary, because you can in most situations move um, after a year. And I also see safety planning would be huge too. Creating a safe place before another option becomes available. So I'm not sure what Decker Towers is, but it looks like it's maybe recovery housing.
Sorry,
Of some
yeah,
kind.
so sorry. I used to work for Burlington Housing Authority, so my mind
Okay.
always goes. Decker Towers is like the largest, tallest building in Vermont, and it has a large population of elderly and disabled. That's actually the only population. That's how you can move in there. But a year and a half ago, it was kind of overrun by drug dealers and became a really unsafe spot. It has since gotten infinitely better, but is still kind of struggling a little bit. So for a long time, providers were really cautious about putting folks in there that may relapse. Unfortunately, it's one of the only buildings that has significant availability right now. And so really being mindful and communicate that with the possible tenant, like this could be a danger and it's your choice if you want to accept this. I don't know that it's the best choice, but like creating a really solid safety plan. So if someone's knocking at your door, how do you handle that? Where do you go? Who do you call when you start feeling like you could snap and like do something you don't want to do? So like if that is the last resort for right now, even if it's temporary, like how do we handle a situation where you maybe don't feel at your best?
Yeah, that's a really great point, and not to do like a shameless plug for the next training, but we're going to talk about substance use and harm reduction in supported housing environments or in kind of group living situations. And that's a big piece of it. I think one, yes, in a situation like that, you might see it because it's all around you, right? And there's risks there. But sometimes, even when it's not in a situation like that, simply just kind of being more isolated and alone can also be a big trigger. And so that planning is really critical, and giving people resources to stay as safe as they can, is really, really important.
Um, the I'm just thinking about what was said by Molly about the like that early assessment where you're identifying sort of like things that are non-negotiable. I
Mhm.
think along with that, at that phase of getting to know somebody, um, like really deeply understanding what their routine is and why it's that way. I mean, some people don't have a routine, but like some do. And I'm just thinking about like one of the last people I moved into housing months back. Like I knew a lot about her. And so before she signed that lease, we stood on the porch together and we like we went and accessed the things that she accesses. And I think just knowing somebody on that level by the time, you're a part of their decision making process or like being a mirror for them while they're making that decision, like you can give a reminder that like, hey, we can take the bus together just to check this out so that there's like an actual understanding and not any surprises when that person makes their decision about living in that place, or you know if they're on the edge of figuring out if that's realistic. It's
Yeah.
good to get on the bus with the person, is what I'm
Yep.
saying.
Yeah, absolutely. I think there's a lot of unknown when you're moving into a new situation, and I think sometimes the unknown can get really big and scary for people. And so what can we do to, like you said, navigate that, show them that it is able to be navigated? Or maybe we do some of those things and we find out it's an absolute, I don't feel comfortable doing this. I don't want to do this. And so then we learn something important there too. And I think with this program, like there's the time to do that, right? Because it's not something that's attached to like a housing unit. Um, so that's a really great point. Thank you for bringing that up.
Now, I'll just say, I think what's elevating is like often assessment. We're like, oh, assessment is the easy part. I feel like it's so multi-layered. And so, because what it is it's how you ask things, it's when you ask things, it's planning. To Marissa's point, like if you haven't asked, like you can ask about preferences, but if you just ask general preferences, then and don't dig in during the assessment at any portion, there's opportunities for miscommunication. There's opportunities for people moving into areas that they're is setting them up for not success. And so I think that's part of why we all do assessment all the time, every time we engage someone. But I think there's so much nuance in how you ask questions, when you ask questions, what specifically you're asking, and how you're wording it, that help people disclose what is an ideal. This moves towards planning, right? Is what an ideal plan for each individual is. It's about how you ask the questions and when you ask the questions and how you establish rapport with them.
Yeah, absolutely. And I just had a thought occur to me, which is like I remember distinctly a lot of times people, like you might not fully anticipate what people's challenges might be, and like they might not sometimes aren't really aware. And so I definitely remember visiting units with people, and it was kind of like it became really apparent um in that moment that there was something about the environment that they were not going to be able to tolerate, but it was something that we didn't necessarily have the information about up front. And so I think normalizing for people during the assessment process that we might change and shift our approach, and that at any point in time people can make their preferences known, because sometimes you don't know you have a preference about something until you see it, and that's okay too. And keeping that, like Jordan said, that strong rapport so that you can have open dialogue. Um, just to go to the next slide in interest of time, um, these are the assessment components that are defined under this program by OEO. So housing preferences include community and regions they would want to be housed, and also unique needs. So do they have pets? Do they need to be really close to a service provider? Do they need to be close to transportation? Is there only certain types of transportation that they're able to navigate at this stage? Is the unit accessible if they have a need there? Um, who is in the household? Also, we're going to identify income, ability to pay rent, and whether or not they need subsidies, which can also be tied to kind of education or employment goals or goals around establishing benefits to kind of improve their situation for those different categories. What are their health and disability related conditions that might impact their housing, their ability to be successful in housing? So substance use, behavioral health, that is tied to being able to maintain housing, physical health, and do they need any accommodations to be able to be successful? We already kind of went over this in the last slide, but knowing what the barriers and obstacles to obtaining and retaining housing. So that would be kind of getting a sense of their rental history and really trying to have that conversation in an open and non-judgmental way, to learn about like what the challenge was. So we're saying, we don't want to know, we don't need to know about this to make you feel bad. We need to know about this because we want to help you be successful this time, and we want to put a plan in place that maybe you didn't have last time. Maybe you didn't have the support that you needed. What kind of support would you have needed in that situation? Or just as important, if someone has not lived independently before, what skills and abilities do they have, and what skills and abilities might they need to bolster to be successful with your support? And then what are the supports that folks have? So natural supports, informal supports. So what services are they engaged with? What documentation do they have? And then we think of supports as like resources too. So do they need furniture? Do they need first and last deposit? Are there resources for that? Do they have their license? Do they have their birth certificate? Do they know what's on their query? All of those things um, are assessment components for this program and would be captured in your housing search plan and housing support and crisis plan. And Molly says wanting to lift up inquiring about natural supports and strengths. Yeah, absolutely. I think again, something that we don't always explore as much as we could, and making sure that, because ultimately a person's life is not going to center around their provider, right? We want them to build that full life that allows them to be successful and happy and well in their housing, and that includes community. And community starts with who are your supports, who's supporting you now. And lastly, I think we wanted to just touch on what some barriers were, and I think we have been a little bit throughout this discussion, which I appreciate everyone jumping in. I know this material is not like the funnest or the most exciting. We're talking about documentation, right? But I guess I want to hear from you all in your experience. What are some barriers to being able to get all of the information that you need to comprehensive assessment? And then also, how are you balancing getting that information with also being trauma informed? And I know we talked a little bit about this if you were in our last training, but would love to hear some things that folks are practicing now. So you can come off mute or you can drop it in the chat.
I think a barrier to getting a comprehensive assessment is a lot of times the trauma that people have been through and trying to do it in a timely manner. We've had a number of people who are really hard to get focused and so working through those pieces to get them off their mind, but then, you know, we're constrained. We haven't started doing this program. I'm just talking about in our other housing programs. We just have such a huge volume of people coming in, and so trying to figure out how to fit them into a schedule that keeps working is really challenging. But I think I'm looking forward to this program because I think the flexibility, hopefully there'll be more flexibility in what that case manager can do around the people that they're supporting. So
Yeah, absolutely. I think touching on the trauma history piece, even just the retelling of things can be really difficult for folks. Or we know something that happens as a result of trauma is general mistrust, and that can be an attitude that people bring into the world after something that harmed them happened. Um, and I think we can all relate to not wanting to spill everything about our lives to this person that we've just met, but especially if we've been harmed in some way in the past. In the chat, I see time. Yes, with large caseloads, always a battle. Yeah, absolutely. Really spending the time with a person, not always just to get the information, but to build the relationship that would allow the information to feel like safe. Um, Talking about it. And then from Ryan, we have letting people I know, yes. And so that's a really good strategy. And I approach that I kind of used to take is like, what's the minimum amount of information I can get to actually take a step forward in this service? And kind of giving people permission not to answer something, documenting that they didn't answer something that can be, again, it's a fine line, right? We have to kind of walk the line of making sure we're getting information to initiate the service and justify the service, but also know that people do not always want to be forthcoming with certain information.
I think it's difficult to like, you have to like represent the system, but also distance yourself enough to not be this like embodied reason why things aren't moving along, And
Yep.
um, I think in terms of like balancing getting information and that in mind, um, your effort to like make sure you're meeting on terms that are like mutually productive, where like I I did an enrollment in one of the library rooms in Brattleboro just because it was so important that this person's phone was getting charged while we were meeting,
Yep.
and it's like, cool, your phone's getting charged. We're like, you know, uh, we're gonna rent this room, whatever, like put our name down for this room so you could have it a little longer after this because you want to be like
Yep.
private and maybe that's not something you do that often. Whatever. It's just like there's so many uh I think that early stage of being like, what's important to you today, and can I merge with that so your time's not wasted? It takes the edge off a lot.
Yeah, and I really like the approach of like you're also focusing on like the immediate needs that they're probably wrestling with every day, having a way to communicate with people. I don't know if someone like are we going to ask them to do an assessment if they haven't had lunch, like, or are we going to get them a sandwich, like what? And so I really appreciate that approach because all of those things can be take precedent over getting this kind of next step completed. And then similarly, I see Travis in the chat having a safe, comfortable space for people in general. Yeah, absolutely. Um, Definitely wanting to feel like their information is confidential, but also, I mean, I'm sure we've all had this experience where we're trying to get something done and there's just like so much going on around us that like of course it's distracting and may be very triggering for someone who's experienced a lot of trauma.
And Teresa, I'll just add that this is a documentation training. So as long as it's documented, right? Like housing support plans can be modified at any time. And depending on your system, that might be an administrative lift, right? So there's that piece that's real and is tension. But I think, often it's if someone is not comfortable disclosing, that is what is documented. And then, we've all had people that several months in told us something that would have been very valuable to have in the beginning, but we were still working on trust with them. And so then it's modifying plans and now we're shifting and this is the priority. So I think, the acknowledgement is in documentation we know we're working with humans. And so as long as we document like the trajectory of what happened and why, that is totally fine because we're all human and we work on emotions and we have to learn to trust people and move past thing. And so I think the reality is that's why we always talk about assessment as not a one and done thing. It's always ongoing, and there's going to be information that we gather later that becomes a priority and was always a priority for them, but they weren't quite ready to tell us that yet.
Yeah, absolutely. Okay. And just to kind of review some best practices, and again, we've been touching on these, I think, all along. One, I think upfront informed consent is really important. And yes, of course, we have forms for that, but I think not breezing through how people's information is going to be used. So why am I collecting this information? How am I going to use this information? Who else is going to be able to see this information? Um, and like, what are our limitations too, in terms of what's confidentiality and limitations to confidentiality, right? Um, Allowing them to set the pace of the assessment. So again, like Jordan said, are we documenting like decline to answer at this point in time? And then like maybe we find out later and we kind of update those documents using open-ended questions, and allowing for refusal, which is really important. And sometimes I think starting from like a non-threatening place, which might be kind of interests, strengths, motivations, can one, I think, help bring that to top of mind when we're doing assessments, because sometimes when we're just asking about the history of all these problems you have, they can just lean a little bit into deficit based conversations. So starting with those strengths and using them as a foundation to build on throughout the assessment process can be really helpful. In certain situations, you may need to utilize collateral context. Might say, can I have a little bit more can I contact this person to get a little more information about that? I've certainly been in um, assessments where people were like, I don't really know why that happened, or I was really under the influence when this happened, or I was really unwell, and you might ask for permission to follow up to get some more information if you needed it and if it was relevant to the housing process. Um, and then using all of our MI techniques, and trying to use objective observations. Are there any other best practices that people here are using that they want to lift up for this process? I think going back to the one that John mentioned, which is remembering there might be immediate needs outweighing or interfering with the assessment process and addressing those. That was a really good example of a best practice. But if you have others, feel free to drop them in the chat or come off mute and interrupt us. Okay. So since we're a smaller group, I think we're going to do this all together. So we're going to do a case example like we do in a lot of these trainings to kind of get people practicing some skills. So I'll just read it out loud. So we have a 35-year-old African-American male who's been diagnosed as schizoaffective and has been living unsheltered for the past 4 years. He was living only on his own until he was incarcerated. He was arrested 6 years ago. The police were called during a behavioral health crisis, and he also had substances on him. So he's spent a lot of time in and out of incarceration, and in between, he has not had housing. He can occasionally stay with his brother, but that relationship is tricky. And he recently came up on the coordinated entry by name list. And though he wants housing, he has been hesitant to fully engage with you. He's been promised housing in the past, so he has that reasonable suspicion of us. Why is this different? He's been let down by providers before, and when he gets overwhelmed or he encounters big challenges, it's easy for him to kind of fall into depression, experience anxiety, which, like, how normal is that when we all encounter big challenges, and increases his substance use. So I'll keep that on the screen while I ask people to weigh in and tell us, what other questions would you ask? What would you want to know about this person? What strengths you see and supports that Victor has, and what barriers to housing might he have? And so let's start with the first one. What other questions would you ask? What other information would you want to know? Yes, and by name list is the CE list, coordinated entry.
I think you would want to know what currently what supports he has for his addiction issues, his drug use issues, and other like his other natural supports in the housing that he's being asked about
Yeah,
in the
absolutely. Who
area.
else are, oh, go ahead. Sorry.
That's it.
Okay.
I would al-
Yeah,
I would also, I mean, if I were engaging with this person, because I myself always hesitate to promise anything. If he had used that language, he's been promised housing in the past, I would make it clear that I'm not in a position of promising anything. I am in a position of trying to work with him to get him into housing. But I'm not a landlord. I don't work for a landlord. All I
yes,
can do is promise that I'm going to work as hard with him as I can. But the
yep,
outcome is something we both strive for.
yep. That's really important. I think a lot of times where people have felt harmed is like something was overpromised or it was made to seem easier than it was actually going to be. And so then that creates a lot of mistrust. So I think that like reality checking, but also like I'm doing this with you, is also a pretty powerful statement, I think. And in the chat for Molly, we have, oops, a lot of people adding to the chat now. Yeah, so kind of like flipping it on its head. So what has reduced your depression or anxiety? What have you done in the past to have successful transitions? Great question. So kind of flipping it on its head and making it more of a strength-based approach. And Marissa says, who is his team, right? Who are his formal supports? Does he have primary care? Does he have a behavioral health provider? And that he's struggles with transition, so maybe digging into that a little bit more. I think also like exploring who his supports are, like has he been in self-help groups? Has he had MOUD? Like any of those things that have been helpful in addressing his substance use would be great. And we have from Katrina, I would wonder with him, I wonder what caused housing not to work in the past. Yeah, and I like the kind of focusing on what we can actually work on together, what's in our purview, what's not. And I see again more exploring those that network of support. So therapists, psychiatrists, more natural supports. What has he utilized to pursue wellness in the past? So thank you everyone for those answers. So next question, what would you see as strengths and supports that Victor has? I mean, I certainly see even making that connection between transitions, depression, anxiety, and substance use, like all of that together, that's pretty good insight. I would say that's a strength. What else do people think? Yep, having a natural support. Like, yeah, so sometimes our relationship with family is complicated. That doesn't mean it's not a support to you. And maybe there's some work you can do navigating that relationship. Still engaging despite hesitation and a pretty tough go of things, I think. You know, we see people establish a lot of mistrust when they are in carceral settings for good reasons. Um, yeah, feeling like they can give, that's a really good one, Marissa. She said, being honest about potential distrust of service providers due to the last promise he had. Like, I'm sure you've been in situations where a person just doesn't feel comfortable enough to like say or give the feedback, like, this has not worked for me before. Um, so I think even that comfort, being able to be direct and name that up front, you don't always get that. That's pretty great. And then lastly, what are his barriers to housing? I mean, Corey's the obvious one, but what are some other barriers to housing potentially in this situation? Yes, Ryan, one more strength, being able to identify all those things that are interplaying for him. That it is. That's it, that's insight. Not everyone has that insight. And I'm just not talking about people we're working with. I'm talking globally. Like, not everyone has that insight. So other than Corey, what's some, and I guess barriers to obtaining and maintaining, I'll ask what some barriers might be for him. Yep. Past criminal history, substance use and mental health challenges that, we can have seen can escalate to a crisis that triggers kind of like a law enforcement response, whatever that looks like. Establishing new trust. Yes, so that could certainly be a barrier to getting things rolling. And it might just, a barrier or just kind of like a little hurdle, like where we have to just invest that much more time in establishing that rapport. Yeah, lack of rental history is going to be tough. And then probably income. I mean, I think that's a good assumption, Katrina, because if you're going in and out of incarceration, we know that um he's unlikely that he had, longer term employment. And also if he were disabled and pursuing benefits, that could disrupt that as well. Right. Thank you everyone for participating, and for giving those answers. Oh, there's one more. Let me get it. Lack of references. Yeah. Yep. And I think at this point I am kicking it over to Jordan, and I will be ready to jump in if you still have challenges with your internet.
Thanks, I switched. We'll see if I can stay on. So the next part of the golden thread that we'll spend some time talking about is that housing search and housing support plan, which is really an agreement between the provider and the individual that's going to guide the course of services and the expectations of what they're going to accomplish together. I think, previously service plans, treatment plans, often people like the archaic way of thinking of is like, this is what we're going to do for the individual, but really this is a agreement between you and the individual of what you're going to work on together based on what was in the assessment. So it's really ensuring that the goals are driven by the individual and it's based on the information gathered in the assessment. And as we talked about, assessment can be ongoing, and so it's changing that as goals change. We all have priorities that shift and focus. And so because of that, it's really reevaluated whenever there's an ongoing change in the individual's desires, goals, needs. And it's really exploring what's needed to complete the change that they've identified or the goal that they've identified, what is needed to enhance knowledge, skill set, resources, anything to kind of support those goals. And so thinking through kind of creating a plan of action with them that outlines kind of what you're going to do, what they're going to do, and really ensuring there are specific components in it. So if you want to click, Teresa, when you think about kind of a housing support plan, what do you think are the necessary components that are part of that plan? And feel free to drop it in the chat or come off mute. When you're thinking of kind of establishing a plan with individuals you work with, what do you think are the things that need to be part of that plan? And for those who have already created these plans, what do you put in them? Identifying potential partnerships, absolutely.
Looks like we have budget and addressing immediate barriers too here in the chat.
Perfect, thank you. All right, so if we want to go to the next slide, thinking about writing our housing support plans, I think these are all person-centered goals, connecting to the biggest picture goals possible, identifying objections, action steps, and who's going to do what, ensuring crisis plans, all of these, absolutely. So thinking about kind of writing the support plans, there's typically like 3 core components. One is that identified need or concern. So this ties back to, why is this person eligible for this service? What is that identified need? But then also during your more in-depth assessment, what are their goals? What are the need or the concern they want to address? And kind of having it in a strength-based and solution-focused ways, thinking about the creation of goals. So exactly what Molly said, kind of what are the big picture goals? So what are your SMART goals? And we'll talk about those moving forward. But then also, what are the objectives to meet those goals? So similarly, following a SMART format, thinking about what tangible steps do we need to reach these goals. And that intervention or those action steps will identify both steps that both parties should take. What is the individual going to do, and what is the case manager going to do to advance it? And just thinking about any plan or anything you've worked on with anyone, it's identifying those action steps really clear, so we know what are you taking on, what am I taking on, how is this going to look as we move forward together. But also thinking of that golden thread, thinking about like if anybody picks up this plan, would they be able to see what steps are outlined, who's going to do what, if there's a staff transition and somebody needs to step in and reevaluate those steps. This is what you discussed you were going to do. This is what my person I'm replacing was going to do. Is that still the plan that you want to move forward? So it's really kind of the agreement and binding contract with them of what each party is going to do to move forward in this goal. And obviously it can be reevaluated and renegotiated as people move forward. So thinking of SMART goals, I'm sure you've all heard of them. How do we ensure housing support plans are SMART? And for SMART often has the A and the R are sometimes interchangeable, but for our purposes, we're talking about specific, measurable, attainable, relevant, and time-based. So if you want to go to the next slide, Teresa.
I think sometimes one of the hardest things is to be, especially in housing right now, is the attainable one.
Yep.
Especially when we're going into a project that doesn't have the natural supports of any kind of voucher that goes with it. So I think that's always a challenge.
Absolutely. And I think the balance, this comes to like assessing and some of what we're talking about of how do you ensure the goals are attainable, and that if that broad base is housing, how are we ensuring those objectives are places we can make progress so the person knows that progress is happening. Sometimes if we have really high goals that might be harder to achieve because of resources, the attainable piece can feel a challenge, especially if it's not broken down into things that they feel like they're making progress on.
I was going to say that exact same thing, which is kind of like making sure it's broken down so that we're demonstrating progress. I think is really important, not just because of the medical necessity piece that we talked about at the beginning of the training, but for the person, it's like sometimes if we don't break it down far enough and it feels a little nebulous, it feels like people are spinning their wheels when in reality they might be making small steps to what can be a very lengthy and complicated process, obtaining housing. So I think making sure it's broken down enough is in those objectives is really important.
Are there other pieces that we feel like when doing SMART goals are particularly challenging or particularly relevant?
I'll just echo Ramsey, the attainable, but then also time bound. Like we're going to have housing on there, but we're not going to use the traditional what does it mean to rapidly house somebody, because those numbers will just maybe be sad.
Yeah, absolutely.
I was going to say the same thing about time bound with housing because I think that process can be a little unpredictable for people too. Like you're not exactly sure what might be a barrier until it becomes one, and so it can be tricky to put time frames on things.
And I think this is where that key piece about assessment and what are the priorities come in. So like the large goal is obtaining housing. The smaller goal, for an individual might be increasing natural supports, increasing feelings around increasing symptom management for some of the depression and anxiety that we talked about with Victor. So thinking through, just running through it, sounds like we're all very familiar with SMART goals. I feel like this is something that if you've been in the field for a while, it's really drilled into our brains, but thinking about like specifics. So specifically, what are we trying to achieve? How will we do it? And how do we know when it's done? So thinking about measurable, how will we know when we've completed it? What is the outcome we're looking at? Are there specific criteria for tracking these outcome progress benchmarks? Thinking about, again, we talked a little bit about attainable. So when thinking about attainable, this broad high level goal might be to get housing, and there might be things that are externally threatening the timeline for that. So what do we do in the attainable part? Maybe it's defining that within the next 2 months, we're going to identify particular units. We're going to talk to landlords. We're going to do X, Y, and Z. Maybe they want to secure employment, and securing employment may open up additional housing opportunities. So the priority focus is focusing on employment for now, and working with maybe an IPS provider, thinking through those pieces, what can be accomplished within the time frame. I think the other piece that comes up sometimes that might be hard is relevant. And I think we see this sometimes with Teresa mentioned in the past, behavioral health providers that are like, if the person's having a lot of symptomatology, it's, oh, this person's going to take medication. Well, maybe that's not what they want to do. Maybe it's not relevant to their goals. So making sure that like it's relevant to what the individual wants and that it's actually contributing to growth. And I think this is where often with housing support plans, there's a lot of latitude because lots of things impact housing stability. And so for an individual, loneliness and isolation might be a concern when they're moving in. And so what's relevant is increasing those social supports. And so that is now the relevant and priority goal for them once they've moved in. They are talking about, I didn't expect to be this lonely when I first moved in, and how are we enhancing those services and making sure that it's relevant to where you are in the journey and where you are in your goals right now. And then time bound. So again, we've talked a little bit about this, but making sure that time limit is realistic. And then it supports time management. So if we're setting goals that are realistic and attainable, but they're not, within the next month we will do X, Y, and Z, as opposed to within 2 days we'll turn this around, or within 6 months we're going to look at 2 apartments. That is a lot of time frame for steps that maybe that person might lose motivation or might have feel like they're not really making progress on something. So it's really kind of working with the individual to see what is realistic and attainable in the next month, in the next couple weeks. What do you want to prioritize? So really looking at what their priorities are. And then I think where there's sometimes tension is, what's coming up in the conversation is that, maybe the aim of the program is to connect to housing, and maybe long term, that might be 6 months, it might be a year, it might be longer. And so thinking through, like, how are we achieving other goals in that time? How are we moving the needle towards housing by focusing on where the individual is and where they want to make progress, knowing that maybe the resource might be external to our control. And so what is within both our control and the individual's control to move forward with that process. So if you want to go to the next slide, we just have a high level example. I don't think this is, again, it would be more specific based on the individual, but if the goal is to get off streets, he'll secure his own apartment within the next 6 weeks in the Burlington area that's walkable with a bus stop. Talking through, is that realistic? If he's just been pulled by the by name list and has a voucher, is it likely that that connection is going to be made in 6 months? Maybe that might be a year. So talking through, this is where the assessment ties into that conversation we're having with people around expectations, and what we can do and what might be realistic. And we likely could find somewhere within a bus stop that might take a little bit longer. Maybe we need to adjust the 6-month goal, and then defining those smaller steps. So this 6-month goal is the broader goal. What are we going to do in the next week? What are we going to do in the next month? Maybe Victor needs his vital documents because he's been coming in and out of incarceration. So within the next week, we're going to work to just complete that request online to secure your birth certificate. Within the next 2 weeks, we'll identify different apartments. So kind of identifying what Victor's going to take in the responsibility and then what staff is going to do. So in this case, Victor will identify at least, 2 housing options that fall within the rental cap for his voucher and his preferred location. And staff takes on the responsibility of supporting him in calling landlords. Maybe he's identified that his anxiety makes it hard for him to engage in those conversations. So staff's going to support him with that process. So this is where kind of the assessment guides what's going into the plan. We talked about your anxiety and depression getting high as things change. And often when you're anxious, you shut down. So would it be helpful if I called with you? Maybe we map out those. So I think this is, again, circling back to the conversation and how do we, based on that assessment, based on the conversations, how do we make realistic timelines and realistic action steps where we both feel like we're moving forward and making progress. And we'll talk a little bit about encounter notes, because sometimes we say, hey, we're going to do this within the next week, and then crisis happens. And so how are we adjusting that plan and then documenting in our encounter notes that this didn't happen and here's why. This became a priority because X, Y, and Z was happening. Because I think you'll hear throughout our training that we're all living human beings, and plans, best laid plans might not happen. So when that doesn't happen, how are we pivoting? How are we changing our plan? How are we documenting differently? And I think if you want to go to the next slide, so thinking about SMART objectives, just wanted to give you, I feel like you're probably doing this all the time, but giving a little bit of an update for Victor. So after several engagements, he opens up to you a little bit more, states that he started using heroin after his wife died in a car accident and where he was also injured. He was taking prescription drugs and realized to help numb kind of the physical pain, and he realized it helped just numb altogether, that he didn't feel as much. So he increased his frequency, and then over time started to use heroin because it was easier for him to get, easier and cheaper. States that he can't imagine stopping while he's still on the streets. However, he's desperate to get out of his current situation. He says that he has saved money for the first month's rent and security deposit, and he's given that money to his brother because he doesn't trust that he won't spend it while on the street, while still using heroin. He would love for his own place, but also tells you that he's afraid to live alone again because he's scared to be alone with his thoughts. So kind of based on the assessment and then the information you have here, what might be a SMART goal for him and what might be some objectives that you would want to work on together? And feel free to come off mute or drop it in the chat.
I think one smart goal would be exploring finding support connections, peer support connections or mental health support to deal with his initial. It sounds like he never dealt with he was busy taking care of his own pain, but never dealt with his emotional pain from his wife dying.
Yeah, absolutely. He's got the initial pain from his wife dying. He's kind of been numbing for a while, and he's also already identified that moving into an apartment where he's only on his own will create more concern and more struggle for him. So that definitely sounds like a priority focus. Katrina says maybe exploring a roommate, figuring out this is part of that ongoing assessment. And so maybe in his preferences, he told you that he was open to living with other people because of these concerns. And so then maybe the smart goal would be identifying, within the next 4 months, identifying potential roommate options, mapping out, you know, ideal characteristics of a roommate, like, even helping him think of like interview questions for people. What would you want to ask? What would you want to know about your roommate? Talking through those pieces. What are other goals or objectives that you feel like might be helpful for thinking through Victor as he moves towards housing with a voucher but has all these concerns? Yep. Molly says not a goal, but love from that love that he's sharing more, trusting, exploring what's going on. That's a huge strength of self-awareness, particularly with money and natural resources. Um, Again, assessment is evolving, and I think that's 100%. Like he has this strained relationship previously with his brother, but now he's also trusting him with his money. And so, what does that relationship look like? Also, that he's aware that he doesn't want to keep the money for himself. Active recovery supports he can call on 100%. Rent payment, setting up a direct deposit, identifying his healthy coping skills. Yeah, so thinking through, when you have those thoughts now, how are you dealing with those feelings, and how do we amplify some of that? And what's my role in helping you support that? And what's your role in helping this? Absolutely. Any other thoughts related to kind of creating it in a smart framework, what you might want to look at or what would be measurable and attainable for him?
At risk of this being too easy, since he's basically there setting up a goal of the measurable, attainable goal of how much money he wants to save, because he's going to get that. And that's something where he can be like fully in the driver's seat for.
Yeah.
Um,
Yeah, and some of it too is like you've already started this goal. Why don't we map out where we want to continue with this goal? Because that gets to, again, the attainable and measurable. You've made progress on this already. Let's celebrate that.
If he
And I think,
choose,
go ahead.
I was just gonna say, if what you identify as a goal and he chooses the finding more support, I think that's relatively easy to put into a SMART goal because seems like in his progress he's being more willing to open up and to reach out. So he might be it may be attainable for him to get some kind of support on that. And you can put into place in a project of, identifying the different kinds of support that's out there and then what would suit him best. So you could put a timeline on, let's look at what types are there, then let's talk about what would suit you best and maybe make a visit together or something to somebody and giving that in a certain amount of time, whatever your regular meetings are, so that he can see the progress.
Yeah, absolutely. And I think some of this is hard to do with a vignette, right? Because you're having give and take when you're creating support plans. You're saying like, and so I think this is again, we're living very in the hypothetical of like identifying what are your healthy coping skills. Maybe that's something that he would want to pursue. Maybe he wants to pursue a roommate. So it's more of the I know we've talked about this and really individual conversation around what works for you, what makes it what's actually realistic within that time frame. So I think all of these questions are 100% like how you would reach that SMART goal with him, because it's again an ongoing conversation, which makes vignettes hard sometimes to actually do SMART goals. So for the sake of time, I think I'll move a little bit on to encounter notes or engagement notes. So kind of documenting your everyday interaction with individuals. So if we go to the next slide, how are you currently documenting, or how do you plan to document your service delivery? Is there a particular format? Is there a particular process? How are you planning to ensure that you're documenting that in the golden thread way?
Molly, maybe you can answer this question. Is it going to be expected that we will all be documenting like notes and all that kind of stuff in HMIS? We don't currently do that for our regular who we put in HMIS. We have an internal database that we use, and then we put in the like we put in people in the project, and then we do the entry and exit and updates, but we don't use it for notes and we don't use it for tracking services. So that will be a different thing if we're all doing it in HMIS, which maybe makes sense. We would still need to do it to a certain extent internally as well, but
Yeah, so it's set up. The request is what you're saying. So doing all of the pieces that relate to reporting, both for, coordinated entry system as well as for this project in HMIS. And then for the notes, you could do that separately. Or you can do it within HMIS. I think that's up to individual agencies.
And I'll say that a fair amount of people document exactly like Molly said, the reporting and the exits in, and then maybe have an internal EHR where they can house because they already have the infrastructure. So I think that's kind of the question. Is there a particular process or format that you're planning to use to ensure that, your documentation is reflective of the plan, which is reflective of the assessment?
and I think we would probably tend to do it the way we do it already so that it's consistent throughout our service provider. All of our housing counselors have the same expectations, which are basically to document. We're trying very hard to do live data entry. It may not work in this process as much, but to keep it as close to live as possible. And we document every meeting and the basics of what are met in the meeting, and keep a paper file with the physical plan, housing plan, and all of that. So we would probably still do it that same way and not put our regular notes into HMIS. And counting services, other than like going in and having them be active in HMIS and then be housed or closed or whatever happens in the trajectory of it.
Yeah, that makes sense. Well, we were going to give you all different. Oh, go ahead.
Yeah, I just wanted to respond. Thank you, Ramsey, too, for sharing and kind of engaging in the conversation. I think that the process, keeping processes similar makes sense. I do just want to make sure people reflect on this in this documentation, that for PSHA, I think it's probably a higher threshold of documentation. And so you're either gonna, I think it can make sense to have a different note template for your PSHA worker, or if you think the note for PSHA, which is a higher threshold, is great, then you could have other people use it. But like, for your other housing case managers, that's a quality issue. It's not though necessarily then tied to, again, this concept of the golden thread, which then includes also billing and then includes like quality assurance and medical necessity and kind of keeping it all together. So I think that absolutely it makes sense to leverage at agencies what you're doing that's working that you can duplicate. But then I would think about especially the content of the note for this in particular to look different, unless again you're having your other notes operate at this standard.
And that's actually a great segue, Lily, because we were going to give a couple different formats or templates that you can use that will ensure that kind of golden thread piece. So Teresa, if you want to go to the next slide, there are lots of different ways that you can do this. And so again, I think it's based on agency preference a little bit. Some people use SERP, some people use PI, some people use all of the, but really the format itself doesn't change very much despite which acronym you use. So we wanted to provide this, and we'll send the notes out as well, but all of these formats really ensure that you are doing that golden thread, that the notes go back to the plan, which goes back to the assessment. And so they're typical formats that agencies have different preferences. Some people like GURP, some people like SERP, but really the meat and potatoes of the notes here is that there's a situation or a goal. So it comes back to, what is the situation that we are working on? What is the goal as evidenced by the assessment? What are the intervention strategies that we tried? What was the individual's response? Did they make progress towards their goal? Did they not? Why or why not? And then what's the plan moving forward? So generally, even if you're looking at SOAP notes, so subjective, what are we working on today that's related to the plan? Why are we meeting? What is the purpose of this meeting and how does it tie back to that original goal? And then objective is kind of what we hoped to gain. Assessment is assessment of what's going on with the individual. What was the assessment of the effectiveness of the objective that we tried to do, and what is the plan moving forward? So all of these formats really help to ensure that encounter notes are, as Lily said, tied back to that plan and tied back to that assessment, that they are, saying, what is the purpose of our visit today? What did we try to do that's furthering their goals? And what was the response? And what's our plan moving forward? So we'll send this out. Again, agencies have different preferences based on the acronym. But for kind of our purposes, we went ahead and highlighted an example of GURP, which is goal, intervention, response, and plan. So Teresa, if you want to go to the next slide. Again, this ensures, part of the purpose of this format is that it ensures that every note is really documenting in a way that ensures you're looking at, why are we providing the service? How is it moving towards that identified need as part of medical necessity, and how are we moving the needle? So again, these formats help to ensure that the necessary content of a note is in that note. So for an example with GURP, it includes the goal, our objective that is restated in the housing support plan. So what is the goal we're working on today? They may have 10 goals, but today we're working on identification for the purposes of applying for housing. And so then the intervention is, what specifically are we doing and what are they doing? So you think about the 6 W's: what, why, when, how, with what intensity, who, and you're kind of mapping those out. This is what we did. This is why we did it. This is how it ties back to their overall goal. And this is kind of the strategies we tried in this engagement. The response is, how did that person respond to it? How did they respond to our actions? How did we respond? What was the mutual impact of progression towards that goal? For example, we've all said, we're going to go to Social Security today. We get there and it doesn't happen. Our goal was this. We had the goal of going to Social Security to apply for, a Social Security card. When we arrived, there was a crisis situation. We worked on de-escalation, coordinated with the mental health provider. All of this is what we worked on. How is it furthering their goal towards housing? It's furthering their goal and that they are trying to ensure, decrease in anxiety, decrease in depression, whatever was in whoever's plan. So for Victor, he was in crisis because he was experiencing high anxiety. We focused on that. That's why we didn't do Social Security today. He engaged in breathing exercises with us. We called his provider. We connected to his provider. He has a follow-up appointment. So if the plan and the goal went off track, how did we respond and what do we focus on instead? But how did he make progress towards that goal? And then the plan is what specific next steps are we going to do that are meeting goals that are identified in that housing support plan, and being really specific. We will meet with him tomorrow at 9 a.m. because we didn't go to Social Security today and we're going to try it again. The case manager will meet Victor at the drop-in center at 9 a.m. to retry again because Social Security was closed, whatever the reason is, a very specific plan so that if I walk out tomorrow and decide I'm done and I quit on the spot, that a case manager can pick it up and say, oh, we got to see Victor tomorrow at 9 o'clock. We're going to pick him up and do X, Y, and Z because that's what the plan stated. So regardless of kind of the format, this ensures that the content is still keeping to that golden thread. And so I think there's an example if we go to the next slide. Oh, no, just tips. So this structured format really helps to avoid that stop and chit chat or just that I think we've all read notes that are just back and forth. I said this, he said this, I said this, then this happened, and that's kind of the note. So it's really ensuring that it it is reflective of kind of what the action steps were, how they were furthering the goals, and where progress was made. So ensuring that documentation is focused on those elements in the housing search or housing support plan, or what is indicated at the time. So if there's a more priority goal that doesn't align with the plan that was in place, that you're telling why. And that kind of alludes to the example that I referenced earlier. Any questions about any of the formats or kind of encounter notes or engagement notes in general? So for the sake of time, I'll go to the next slide because I think that we're going to get to an example eventually. So other elements of an encounter notes. Encounter notes should be intentional and purposeful. And this gets to what Lily was talking about the note should really be for the purpose of the plan and the purpose of the assessment. So what are we hoping to gain in this? And that you need to document each encounter, even when contact isn't made. So it may be non-billable because we didn't see them, but we went out, we attempted to engage them like we said we were going to, they weren't home, that we're documenting that. And then thinking about kind of what's submitted in claims, thinking about that the note is documented, that the location of the service is documented, that the appropriate code is there, that the date of the service and the duration of the service is there. And when thinking about documenting notes, thinking about that the note supports the duration. So if you have an encounter note that's 3 lines long and you met for 2.5 hours, that doesn't really do justice to the amount of work that you focused on or what you were doing to support the individual during that time. So making sure that if there's a duration of services, that there's enough content of what were we doing during that 3 hours. Maybe it was waiting on Social Security. We were waiting at Social Security, but we were also engaging in conversations about natural supports or helping them do breathing exercises because they've admitted going out in public makes them really anxious. And so we're working on kind of what are their coping skills, that we were also, making other phone calls to work on housing applications, leaving messages with landlords so that we're kind of supporting on multiple things with the individual. I know we're coming up on time, so if we go, this is an example. So an example of we used the SERP format, which is situation, intervention, response, and plan. This is not a great note. So we wanted to talk about how we could make it better. So the situation, Victor lost his identification last week. He was recently matched to housing through opportunity through coordinated entry. The case manager, Susan White, engaged Victor around identification. Case manager supports Victor in calling Social Security office. Victor says he's doing fine, called Social Security with case manager, but they were not able to make contact. Reported he will try again with his buddy's phone, and if not, the case manager, he'll go with the case manager next week. The plan is that the case manager will visit Victor on the 17th at 3 p.m. to escort him and going to Social Security. Signature, it was a 47-minute meeting face-to-face at a drop-in center. How might you make this note a little bit better to ensure that you're really meeting the plan, that you talk about the goals, how it moved forward in progress, or and then that it sustains that you talk to him for 47 minutes.
It seems likely that you would have been, I mean, I think like the first note maybe to say how important identification is for getting into housing, and then probably talking some more about that housing opportunity, because it seems likely that that would have been part of the conversation.
Mm-hmm.
Yeah,
Absolutely.
I was gonna say something similar, like maybe if there's a deadline to housing, or if he's like viewing the housing soon, like putting information about dates and stuff as to like when they need to have that done in case like something happens and Victor can't go to the Social Security office on that day either. Like how long do they have before they lose the housing opportunity?
Yeah, absolutely. So more information about why it's important, what the timeliness of this, what might be in the plan. Any other thoughts?
This is not to answer your question, but just
Sure.
to note, at least at this point, we are, because we're using the per member per month rates for this project, we are not required to do the time piece. We are required to
Okay.
say, place of service and face to face.
And I think that's a good point. Per member per month, there's a little bit more flexibility and latitude in some of the documentation pieces, but we kind of train on some of the other pieces, because if you're doing it well, this is how you ensure kind of that golden thread piece. But I think, the time stamp is often associated with fee for service, which is definitely a rigorous documentation process. But I think even in doing a quality review at your agency, looking at notes and saying, I know that person was there for 3 hours and we have, two lines of notes. Maybe we'll talk a little bit about how they can document more robustly what they're working on. So for the sake of time, I'll go to the next slide.
Real quickly, I think it's also interesting to like look at this not just as requirements, but and I think Jordan, you were kind of saying this too, but like what does it tell you? Like, oh my gosh, I am meeting so long with X person. Like, what's going on? Do we need to lean on into this situation? We used to just meet for an hour, now it's 3. Also, like, are there certain times of day that you're showing up and it's more likely to be like a no-show versus others? Like, and like, so some of that data can also just be interesting for you from a quality perspective and like from a planning perspective of like, gosh, when I meet with Lily in the morning, it's a disaster. When I meet with her in the afternoon, it's so much more productive. So there can be themes that time can tell you, although to Molly's point, at this point, it wouldn't be a requirement.
Yeah, absolutely. I think and that's part of the like supervision and quality assurance management review too, is looking at, in supervision, we're talking about meeting more. Is that because we are getting more in depth into some of these other needs? And do we need to pivot what's on the plan? Think about like more intensity of services. Maybe we need to increase natural supports, or sometimes we're meeting less frequently because this person's doing really well and they have more natural supports. And how do we kind of titrate some of the services that we're offering, or change, what we're focused on a little bit? And we're going to send these slides out, so I won't kind of read this, but this gets to some of what you were talking about, that, okay, why are we doing it? Well, he's tried to go to Social Security on his own a few times and has missed appointments. So we kind of gave him, he wanted to try it on his own and it wasn't successful. So now we want to make sure that we're setting him up for success. Maybe it's going with him. He says that he wasn't successful because he was panhandling and needed to get money for food. So addressing that immediate need, like people had talked about before. So we decided that we were going to go to the food bank, we're going to get him lunch, and then we're going to go together to make sure that those basic needs are met so that he can get to this other goal. Because it sounds like panhandling was getting in the way of him getting to the Social Security office because he wanted to make sure he had enough money for X, Y, and Z. So kind of looking at this provides a more robust picture of what the case manager did in the meeting. What did they assess for? What questions did they ask? Why hasn't it been working out that he went out to he was trying to go to Social Security on his own? And so kind of engaging and prompting him, what strategies have you used? What's worked in the past? Will it be better for us to go together, creating that plan, and then kind of having the plan in the in the notes? And I think from like a supervision and quality assurance perspective, reading this note versus reading the other note, you get a better understanding. And again, that golden thread is about, how do we read this chart and know exactly what happened, know why things took longer time, why, maybe there were bumps in the road. And so somebody reads this in a few years and says, oh, it looks like, in the past, panhandling was creating an issue for making appointments. To Lily's point, maybe we meet later in the day, maybe we meet early in the afternoon so he can get back for prime panhandling time. So kind of creating interventions based on what we see and read in the notes. So I know we're bumping up on time, so I will go to the next slide. And then I think, Teresa, this last part is you.
Yes, it is. And I will try to zoom through it so we have room for questions at the end. But we've been over this about multiple times during this training. We all know that if it isn't documented, it didn't happen. And so, but we also recognize there are challenges to doing this in the way that we might want to do it. So, common pitfalls that we sometimes encounter in assessments, and we'll go through each category on this table, is, and we touched on this before when we were talking about maybe getting collateral information if we have permission to do so, that some folks might have limited information, hard time remembering, or kind of like gaps in their history. And I think some of the categories that we've talked about that this program will serve, it lends itself to that. Like someone might have had a kind of like a long run of substance use and they might not have the clearest memory of certain things that they did during that time. Or maybe they have a brain injury and that's really significantly impacting their ability to recall information at some point in their past. And so that's certainly a pitfall we can fall into. And again, one strategy, though there's many, one strategy is to say, hey, like I'm noticing you're having a hard time recalling this. Do you have someone that you were working with at that time that we could get more information from that would be okay with that person? Some other pitfalls is like we don't quite establish the justification for the service. We also touched on that it could be deficit based. We can fall into that trap. And I think might have been you, Molly, or someone else lifted up kind of shifting to thinking about strengths and reframing the way we're thinking about to make sure that we're really strengths based and we're drawing on their resources to achieve the goals that they identify. And then always, if we don't treat it like a living document, it's eventually going to probably become irrelevant over the course of the work because you learn information and things change. Things just change. When creating plans, not another pitfall could be not reflecting like the true needs and wants of the person and just saying something like get housing, or the one that we always default to, for example, is med management, because people tend to prioritize that so highly, but is it a priority for the person? Like how are they really being impacted? Creating plans that are really driven by kind of the agency, and not so much by the person's needs. So like an example that I will lift up is I had a gentleman who I worked in an open access healthcare clinic. So you could walk in and you had to see someone once a month to get your medication. And so he would come in for therapy, and the rest, like the psychiatry team, was very focused on this person taking their meds. And we had a big conflict because he was hearing voices, but he found them supportive. And he didn't want to minimize those symptoms. And so in that situation, the psychiatry plan was not really being driven by the person. Rather, it was being driven by what the psychiatrist thought. And then making sure we're being really careful about tying goals back to like the need that the person identifies. And sometimes having a challenge like identifying or breaking down goals small enough so that they feel achievable, so they reflect progress over time. And then lastly, an ongoing documentation. You're doing something and you're documenting it and it doesn't connect back to the goals. And we would want to think, and certainly things happen, but we would want to at least say why that was. Or we would maybe, that's a sign to go back and revisit those goals if we're consistently focusing on something else. Extraneous details. So Jordan gave the example of like line by line what people said. So if you left tomorrow and that person had to pick up for you, are they really going to be able to move forward going through line by line, or it would be more helpful to have enough detail so it talks about what we're working on and why we're working on it, versus having to sort through all of that and kind of come to your own conclusions about it. Does not reflect progress or canned notes. Worst thing I see is copy and pasted notes, where they only change some details. And I know that everyone's crunched for time, but it's really not good practice. And strategies to enhance documentation. Concurrent documentation. If you don't know what that means like trying to do your documentation at the end of your session, even maybe with the person, especially if it's someone that is worried about what you're writing. Or like write immediately after. Some people have a way to use voice notes to get it into their EHR. There's a bunch of different strategies, but it supports time management and it also keeps everything really fresh in your mind. And then, of course, having QA reviews. So as a supervisor, if you're supervisor on this call, making sure you're checking with a regular cadence that documentation is up to the standard that you need it to be and really reflecting the work that's being done. And completing chart audits, we recommend quarterly. And then lastly, that living document, the assessment, always returning to assessments and ensure things that need to be updated are updated, or shifted and changed are shifted and changed. And so we are over, so we're not going to get to our case example, but we will send these out, and we hope that this was helpful, and we thank you for your time today. We're sorry that we had some technical difficulties and went over, but we really appreciate you sticking with us, and hopefully maybe when we send the case example out, it'll be useful to kind of reflect on what you learned today. So thank you so much, everyone. We really appreciate you being here with us.
Thank you.
Thank you all.
Thanks, guys.